Now, carrying on our thinking about the signs and symptoms that we can see in anaemia, we notice that anaemia causes hypoxemia, a reduced amount of oxygen in the blood. And actually, this is what anaemia really is. Anaemia is a reduced oxygen carrying capacity of the blood. And when the oxygen levels in the blood drop, that's going to be detected by chemoreceptors. And these are located in the large arteries, the aorta and the carotid bodies, just off the carotid artery. And what they do is they send messages to the brainstem, the medulla, the medulla oblongata, the lower part of the brainstem, which contains the cardiac centre, the vasomotor centre and the respiratory centre. So when these chemoreceptors detect oxygen lack in the blood, the medulla oblongata is going to respond by increasing respiratory rate. Increasing respiratory rate and depth of ventilation. In other words, there's going to be what we call a tachypnea. The respiratory rate is going to increase even at rest, and it will be particularly increased during exertion, so there'll be a short of breath on exertion. The patient will become more short of breath on exertion, SOBE. And as well as that, the medulla oblongata, when it detects oxygen lack, is going to increase overall sympathetic. Outflow. There's going to be an increase in sympathetic activity. Let's just carry on with the increase in respiratory rate first. If there's an increase in the respiratory rate, that is a tachypnea. The patient is breathing faster, and especially short of breath on exertion. Then the effect of that, because they're breathing faster, that's going to increase oxygen saturations. So the breathing faster will increase oxygen saturations. The blood as it goes through the lungs will be more saturated, optimizing saturations. But we've also mentioned there's a increased sympathetic outflow. So the hypoxemia is going to increase sympathetic activity. Of the autonomic nervous system. Now, if you increase sympathetic outflow, if there's increased activity of the sympathetic nervous system, what's that going to do to the heart rate? Well, as you probably know, that's going to increase heart rate. And it's also going to increase stroke volume. The heart will beat more times per minute, and more blood will be ejected per cardiac contraction. And this is going to give rise to clinical features. So one of the clinical features we have in anaemia is a bounding pulse. The pulse is more bounding than usual. And it can also lead to palpitations. The patient becomes aware of their heart beating. So again, we can highlight the clinical features here. Bounding pulse, palpitations. increased respiratory rate. These are things we actually see, or the patient reports, tachypnea, shorter breath on exertion. Right. Now, the reason that the heart rate and the stroke volume increase, the reason for this is because together these two will increase cardiac output. They will increase cardiac output. So you can see now we've got improved oxygen saturations and we've got increased cardiac output. And both of these effects are going to increase what we call oxygen flux. It's going to be increased oxygen flux. Now, to understand this, we do need a bit of background physiology. And that background physiology is described in this equation here. So we need to understand this equation. So oxygen flux, that's the amount of oxygen going from the lungs to the tissues. Flux means movement through. And that oxygen flux is determined by the cardiac output. Now, the cardiac output is the volume of blood pumped out by the heart in a 1 minute period. And it's defined as heart rate multiplied by stroke volume. So the heart rate is the number of times the heart is contracting per minute, say 70 times per minute. And the stroke volume is the amount of blood ejected by the left ventricle per contraction, say 70 times. So you can see from that the cardiac output is going to be 70 times 7, which is 4,900 mils. So the cardiac output is the volume of blood ejected by the heart per minute. And I think you can probably see that if the cardiac output is higher, so suppose the cardiac output was normally 5 litres a minute, but with compensations that rose up to 7 litres a minute. Can you see there's more blood going through the circulatory system? Therefore, even although there are fewer red blood cells, they're going around more quickly. So the delivery trucks or the delivery men are running around in circles faster. So that's going to improve the overall oxygen flux. So that's why if we increase cardiac output, that will increase oxygen flux, because the blood is going around quicker, delivering the oxygen more quickly. But we notice that oxygen flux is cardiac output multiplied by oxygen saturations, which is the next term in the equation, oxygen saturations. So the more saturated the blood, so the oxygen saturations describe the proportion of the hemoglobin that is saturated. And the nearer 100% that is, obviously the more oxygen is going around to the being circulated round. So increasing oxygen saturations will increase oxygen flux. Increasing cardiac output will increase oxygen flux. And we can see that's exactly what the body's done. It's so clever. It's increased respiratory rate to increase oxygen saturations, therefore improving oxygen flux. The oxygen lack has been detected by the peripheral chemoreceptors in the large arteries. That's gone to the medulla oblongata, which has increased the respiratory rate, but of course it's also the medulla oblongata which increases the sympathetic outflow. So the medulla oblongata is also increasing the sympathetic outflow. It's kind of going around there like that, isn't it? So the medulla oblongata is increasing the sympathetic outflow. The increased sympathetic outflow from the cardiac centre in the medulla oblongata is increasing heart rate and stroke volume. We can detect that by a bounding pulse. The patient can feel the increased stroke volume, can feel the increased heart rate, these unpleasant palpitations. But can you see their compensatory mechanisms because they're increasing cardiac output? If you increase cardiac output, you're increasing oxygen flux. So the improved oxygen flux is to compensate for the hypoxemia. It's a compensatory device, which of course is good. We're compensating. The tissues are getting more oxygen. So the improved oxygen flux is going to reduce tissue hypoxia. So improved oxygen flux means less tissue hypoxia. The tissues are getting more life-giving oxygen. But the increased heart rate and the increased stroke volume is going to increase the workload of the myocardium. So we get increased the heart's having to work harder. This compensatory tachycardia, the compensatory increased stroke volume, all going to make the heart work harder. Okay, for a short period of time, but this can go on for a long time, of course. Especially problematic if it's associated with other deficiencies such as vitamin B deficiency. But over time, this is going to increase. Like if you go to the gym and work out, muscles are working harder, the muscles are going to get bigger over time. So it's the same with the heart. We're going to get ventricular hypertrophy. And other damage to the myocardium. The heart's going to be enlarged. On the chest x-ray, of course, you'll notice that as a cardiomegaly. Long-term complication of anemia. But over time, the ventricular hypertrophy, over time, it will no longer be able to compensate by just getting bigger. It will decompensate and we'll get heart failure. So we see that a long-term complication of anemia is heart failure. And of course, heart failure is also a cause of anemia. So once there is some heart failure caused by the anemia, we get into a vicious downward spiral of heart failure. In heart failure, there can be a left ventricular failure, and that's going to lead to pulmonary edema. It's the LVF that leads to pulmonary edema, and that's going to lead to soggy lungs. And the clinical feature we might notice first is orthopnea, shortness of breath when the patient is lying down, particularly relieved somewhat when the patient's sitting up. And the heart failure, of course, will affect the right ventricle as well. Right ventricular failure. And the right ventricular failure is going to lead to increase in the venous pressure in the systemic veins. So this can lead to systemic edema. So you'll notice probably swollen ankles first. And also if you look for it, you'll notice there's an increase in a jugular venous pressure, increased JVPs. So we can notice the systemic edema indicating the heart failure. We can notice the increased jugular venous pressure, indicating heart failure, as indeed does the orthopneos. It just affects the different sides of the heart. So the right ventricular failure, systemic edema, the left ventricular failure, pulmonary edema. There is a whole series of videos where we cover this in great detail. In the Campbell Teaching channel if you wanted to watch those. So we see the clinical features, shortness of breath, lying down, edema, later features, complications. I really do hope you can treat your patients before we get to this stage. It's appalling that such pathology should be caused by most commonly simple iron deficiency in the world. Such a simple thing to treat. But you can notice before that a bounding pulse, patient complains of palpitations, patient breathing quickly, short of breath on exertion. But we notice that these are compensatory mechanisms to improve the oxygen flux. So we get more oxygen going to the tissues, which is exactly what we want. And that's explained by the fact that the oxygen flux is increased by improving cardiac output, or raising cardiac output beyond normal, raising it beyond normal and maximising oxygen saturation. Now we do notice that the oxygen flux is also dependent on haemoglobin concentrations, but usually the whole problem in anaemia is that the haemoglobin is not enough. There's not enough haemoglobin. But the oxygen lack will stimulate the kidneys to produce erythropoietin. But of course, if the bone marrow does not have enough iron or enough B12 or enough folic acid to make the red cells, then the increase in haemoglobin compensatory mechanism, unfortunately, is not going to be available to the individual. But if someone's got iron deficiency and you give them iron, then they'll be able to compensate. If they're short of B12 and you give them cytamine injections, then they'll be able to compensate. If they're short of folic acid and you give them folic acid and advise them how to get folic acid from the diet, then they'll be able to compensate. Then when the haemoglobin concentrations go back to normal, that means the patient will essentially no longer be anemic. So the tachypnea, the fast breathing rate, won't be necessary. The patient will no longer be short of breath on exertion. Because the blood's carrying plenty of oxygen, because there's plenty of haemoglobin to carry the oxygen flux will be adequate, so the cardiac compensation will no longer be necessary. So the tachycardia and the increased stroke volume, all designed to increase cardiac output, will no longer be necessary. And the complications, the long-term complications associated with that, won't occur because of your interventions. Bit of a congested sheet of paper, but it still managed to fit just on one side.